good morning everyone again. Let's start talking, because if I don't start talking, they'll not stop talking. So, all right, okay, settle down. So, you heard Professor Prabhakaran talk about NCDs and specifically certain nutrients and diet fractions which were important in terms of NCD causation, right? And how we can go about in terms of policy angles and others for prevention as well as management. Then you heard Usha talk about the whole spectrum of maternal child health, where she was not only talking during the pregnancy or the first 1,000 days, but also preconception and or periconception, whatever terminology you would like to use. And so this fits in very nicely, because now we will talk a few things about policy aspects in India for overweight obesity. So what I wanted you to focus your attention on was, yesterday we discussed a lot about determinants, we talked about prevalences, how obesity is measured, so on and so forth. There was not a lot of details though, but today at least I think compared to yesterday, we still have a little more to discuss in terms of what's happening or what should happen in the overweight obesity space in India. So day one, yesterday we did those, and today we will focus more on policy interventions. I've kept it more India-centric. I do bring in some examples which have been successful outside, but hopefully we'll keep the discussion to our Indian settings, because we see that there's a lot of gap and a lot of work which needs to be done in this space. Just as a recap, in terms of facts and figures, again re-emphasizing that within the last decade, we've doubled our levels of overweight obesity. 25% of Indians are at the risk of dying from one of the NCDs. 80% of heart diseases and diabetes can be averted by simple lifestyle modifications and a nutritionally balanced diet. One in 10 people aged 18 years and above have high blood glucose, and this is from the CNNS data, which Praveen will be talking about post-lunch. There's also 2/3 of adolescents who are physically inactive as per WHO global standards. The crisis of obesity in India is only expected to get worse, especially amongst the young people. And you know, Modi ji and other leaders are all talking about taking benefit of the demographic dividend that we have, that India is going to have more young people than other countries. But what do we do with the sick young people is what we should also think about. So together with India, India will also be a chief driver of the explosion of childhood obesity by 2030, when about 250 million children worldwide will be obese. In India, more than 27 million children will be obese by 2030. And India will surpass US as the country with the second highest number of obese children. So in terms of what's happening so far, we started off so when we are talking about MDGs, people spoke about these a little bit, but I'm going to emphasize a little more. The MDGs, the Millennial Development Goals, which gave you the target for 2000 to 2015 to end poverty in various dimensions. The global burden of disease data in 2010 was published in Lancet, which showed that 2.8 million deaths was because of poor diet, and therefore 2011 series looked at globalization of food systems and how that was promoting overconsumption of energy-dense, nutrient-poor foods and beverages, and that was identified as a major driver of obesity. So we start talking about the overweight obesity from 2010 onwards. 2012, still not India though, it's global, okay? People don't recognize that as a problem still, which is very surprising, but in 2012, the WHO Comprehensive Implementation Plan on Maternal Child Health, as well as infant-young child feeding practices, specifically gave the target that there will be a zero increase in overweight children. So that also started, dwelling upon our minds that there's something which is happening worldwide. 2013, WHO's Global Action Plan for Prevention and Control of NCDs was a landmark document. You all know that the NCDs focus and everything happened. This document was a land piece. And their framework also was premised largely on overweight obesity, targeting and calling out for a zero increase in the prevalence of obesity. 2015, you know that UN General Assembly adopted the SDGs for the 2030 Agenda for Sustainable Development, And 2015 Lancet series also was devoted to all of these forms of malnutrition. There's one which is happening a few days afterwards, which is the 16th December launch, specifically again focused on dual burden of malnutrition, and we await all the series of papers which will be talking about overweight obesity as well. Now coming to India, what happened in 2012 and 2013, that the NCD screening and prevention program under MOHFW, the Ministry of Health and Family Welfare, starting to get drafted, was piloted in several states. It did not take the shape of a full national program, and the government changed, and those programs get stalled, and so on and so forth. 2015, there was a committee for specifically by the FSSAI looking at the adverse impact of HFSS foods. This is what we discussed yesterday, the high fat, sugar and salt consumption. And I'm going to go into the history of this a little bit. It's important. The 2018 Eat Right movement and several of the components will also be discussed. 2019, the trans fats elimination by FSSAI started happening. And this is more from the overweight obesity lens that I'm focusing in terms of programs. There are others also for malnutrition, but this is what we would focus from the overweight obesity lens. Most of you may have seen this. If not, it's a good piece. You should read it. It's a 4-pager policy brief by WHO, which actually started, diagrammatically or pictorially representing that equal emphasis on overweight obesity is urgently required. Okay, we have been rightly obsessed with undernutrition, which is fair, but also the attention should not be limited to that realm, to that sphere, but also widen your gauge and go on to attacking overweight obesity right from early on. There were also supports from other organizations like the WCRF, the NCD Alliance, which also formulated smart commitments to addressing NCD's overweight and obesity. And at this point, let me tell you, from 2010 onwards till 2020, 2019 is already here. In this last decade so far, there has been a lot of global reports, lot of global advocacy for nutrition, for malnutrition, which also talks about overweight obesity. There have been foresight reports, Global Panel of Agriculture and Nutrition was there, and food systems. There was Global Nutrition Report. You must have heard it started in 2015, then 18, then 19. So there is a Global Nutrition Report which summarizes both these forms of malnutrition, but specifically does pay importance to overweight obesity as well. I don't want you to look at these studies indirectly, but what I wanted this slide to do is to be able to demonstrate that there were studies after 2012 that started happening, or at least started documenting that there are ways we can tackle this in India. So whether it's Thakur's study where 20 weeks lifestyle intervention program was looking in decrease of weight and waist circumference, or it's a study in Chennai which looked at 20,000 students and saw that if you are, you're having a curriculum which is very comprehensive, including nutrition, psychology, exercise, yoga. It improves the knowledge, but also the obese children get that subset of obese children performed better in those tests. There have been some other tools looking at sports, physical activity, and eating behavior things amongst children and adolescents. Where TV watching was one of the criteria. They saw that so they started documenting. What I mean to show here is they started documenting that yes, overweight obesity is creeping in our societies as well. And then came the Niti Aayog's very ambitious and aspirational program of National Nutrition Strategy 2017 to 2020, which said that, and the target was Kuposhan Mukt Bharat, which is malnutrition free India by 2022. The dual burden of malnutrition, again in policy documents, started featuring. So they also talk about the dual burden, they talk about overweight obesity, although just the mention of it is there in most places. The planned action or steps to tackle these was not illustrated in the document, the policy document. There were some core strategies, though, which can be extrapolated to the overweight area as well, which included governance reform, leading by example, like the case narratives we were discussing in undernutrition. There could be similar cases in India. As of now, none of the states have shown a decrease. They've either stayed the same. The recent most data showed that they've either stayed the same or have increased. There's not even a single state which has shown that they have been able to take care of the overweight obesity problem. Convergence was a core piece in this. How to prioritize action to reach the critical age groups continuum of care across the life cycle, which all of us have started talking about, and it started featuring. It was more in research domains, this life cycle, life course approach, but it started featuring in policy documents as well. You don't seem convinced, and we'll talk about that. Community-based monitoring and enabling actions. This is just a cut paste from their strategies, which, because they modeled it on the WHO SDGs criteria, where they're talking about decrease in stunting, decrease in anemia, decrease in low birth weight, but they mention this, that they ensure that there's no increase in childhood overweight also. Increasing the rate of exclusive breastfeeding, as well as reducing and maintaining childhood wasting. I also want to talk about the National Food Security Act 2013, which was primarily as a hunger removal strategy by policymakers. So this was targeting very poor BPL families, the below poverty line families, to be able to give them subsidized grains, largely rice, wheat, and millets. Millets never came in most of the things as per the reviews which were published later. It was mostly rice and wheat which was pushed through this National Food Security Act. These were distributed under the PDS to the below poverty line people, which of course we see them as malnourished, in the sense, for them malnourished means undernourished, and therefore rice and wheat was supposed to be given to take care of food security. A lot of critique and lot of work went around trying to lobby to include pulses and coarse grains, these millets, for the sake of nutrition security, not focusing merely on food security. And the difference between the two is that removal of hunger is fine, but what happens to the balance of nutrients in the food? So as researchers or as policymakers, we wanted them to be able to focus more on nutrition security rather than food security alone. This slide is a very recent one, and this paper is there in your packs, but essentially people talk about PDS all the time, and overburdening of PDS and corruption is the whole sole charge, but this paper actually goes out and tags various determinants that affect the effectiveness of PDS, and how linkages between PDS and NFSA, that is the National Food Security Act, are sometimes acting as barrier instead of facilitators. So whether it's increment in wages, whether it's the staff, whether it's problems in diversion of funds, so on and so forth, availability, procurement issues, how the whole thing pans out is important for us to keep in mind. Okay, so the one key all of us in India at least have heard is Jan Andolan. The Prime Minister talks about this a lot when we talk about any nutrition program. Now, what happens to Jan Andolan in overweight obesity is so I was trying to look for examples, and I found that in 2002, there was a group of overweight children in New York City who filed a suit against McDonald's, for compensating their obesity-related health problems. So this actually went to trial, went to court, improved nutritional labeling of McDonald's products and funding. This litigation provoked an intense, mostly negative response in the news media and court of public opinion. However, on similar lines, you all should be aware that there was a PIL filed by Uday Foundation also. That's an NGO which works at congenital abnormalities and other things related to school children and their health. But this particular PIL was on the availability of bad foods, they say, in the school premises, or where the children can access it, worsening their health. So this was the first time the policymakers started discussing that there is a serious need for collating energies and documenting a policy guideline for HFSS foods particularly. So this had a huge role, though, and this did not come from any research group per se, but from people who were affected by these events. So FSSAI, therefore, from 2015 onwards, started taking these things very seriously. They constituted a number of committees. The committees were there before too, and I'm a part of several of them, so I know we just keep doing meetings. Many people ask, what do you do except meetings? So, or coming up with some minutes of the meetings. Other than that, nothing really flows down in real space. So, but this at this time, this is an opportune time, because somehow the efforts have started to see some shape in terms of collating. So the Eat Right Eat India movement, which FSSAI launched in 2018, very recently, but it focuses, or at least it mentions all the right words, holistic and collaborative approach with stakeholders on both demand side as well as supply side, and trying to find what kind of steps can be taken to overcome these things. And they see now the Eat Right is not limited to undernutrition alone. The Eat Right movement is also trying to incorporate in a big way the overweight obesity burden, which people are cognizant of now. So on the demand side, they are trying to empower citizens to make the right food choices. How? Yesterday we did the nourishing framework by labeling, for example, by strengthening labeling laws, by giving nutrient compositions, or by banning advertisements and restricting those kind of medias so to advocate aggressively for junk foods or unhealthy foods. On the supply side, it also nudges food businesses to reformulate their products. So they are saying that the onus is not only on the consumer, but also on the supplier to be able to produce healthier foods so that you have access to them to begin with. They try to summarize three major movements under this Eat Right movement. The first is the SNF Initiative, which is the Safe and Nutritious Food. The second is the Eat Healthy campaign, and the third is food fortification. So when we say SNF, essentially what it does is it divides us in 4 blocks. We at home, we at school, we in the workplace, and in other public places. So these safe and nutritious guidelines have come out in the form of very readable, simple books, which are pink book, yellow book, orange book. I don't know if you've heard of this, but if you've not, FSSA websites gives a free copy, you can download them free. They are basically very, very simple ways for people at home to take care of food safety, for example, how to keep the food safe and feed the children right. And in terms of school, how the education should be focusing on starting early in terms of telling people to telling children to make better choices in terms of foods and nutrition. It also focuses on disseminating knowledge through community outreach and providing training for staff or capacity building for food safety and nutrition. FSSAI also has a trans fat elimination pledge, a voluntary pledge as of now, but they plan to say that the cutoff in the trans fats at the industrial level was 10%, which has been brought down to 5%. And those of you who understand this, it's a huge ask. It was a huge ask, but the industry have come forward and they have said that we agree with this. And as of now, it's being in it's underway, the changing of machinery, changing of norms and standards. So they have a committee, a special panel on oils and fats, and I'm a part of that. So there's been a positive response, at least from the industry, for this side. I don't know what the real picture will be, but at least as of now, the reports which we've got, the periodic reports, seem positive in terms of favoring the products towards eliminating trans fats from the food supply chain. And Pawan Agarwal, the CEO of FSSAI, has actually shifted the target 1 year earlier. So the WHO says elimination of trans fats by 2022. We have focused it on 2021. So we say that India will be trans fat free by 2021. So we know that 1 year will be like a buffer period for us to catch up in case if we lag behind somewhere. But this also, trans fats also are a big problem. And if you see the bad fats related with health outcomes, overweight obesity is also one of those, and therefore this is important from that lens as well. The Prime Minister has a particular interest in exercising and yoga, if you all know that. So he has launched a Fit India movement last year on the Yoga Day, and he says this is to encourage Indians to participate in most exercises. I don't know how many of you know this, but most of the government offices on national holidays or on celebrated days like these actually have to go and spend an hour doing, yoga and doing these things. It may be, I know we can laugh about it, and I'm not a big fan of, I'm not revealing my political preferences, but the point is that he is actually the celebrity endorsement that we talk about all the time. If the Prime Minister itself is doing it, there are so many levels at which it percolates down. And especially the people at the bottom sometimes, when they can relate with him that, yes, this is ours and this is our heritage and this is what we should do, perhaps it will send out a positive message. So this may have implications for policy as well. The HFSS guidelines is funny and weird, but it's like it's sweet and sour. I've been up with it from 2013 13, yeah. And now it's 2019. Our guidelines have still not seen the light of the day. Unfortunately, they have come up with at least a better version of guide, which is available for public comments now on the website. And those of you who are interested, please look up and give comments. This is available there. They give out, I have prepared 7 recommendations when I was a part of committee. 5 of those are intact, at least, which included advertising ban, which included, celebrity endorsement not taking place for these. And in fact, using social advocacy or media advocacy for positive influence. Labeling also was a very strong highlight which we had, and that's being adopted. It's still not come out, but you will hear that hopefully very soon. Traffic light system is being followed, where they're trying to say whether it will be orange and yellow or green and things like those. And so there was a whole debate whether this is too confusing for normal people. So this is being done for sugar, for fats, and for salt, for sodium. Okay. So all these 3 HFSS items, so they said we'll give one green if it's in the correct range, one item will be green, the other 2 will be yellow. What does that mean? And so there was a lot of discussion around these things, how to harmonize this. It's a difficult decision, how to make something very easily understood by you, okay, we may be a part of the elite group who understands and who reads labels, but perhaps people outside don't. So how much of a weightage this is, and should there be primary studies, involved, collecting behavior change, who reads labels first of all, and how much time do they spend? Do they understand those things within that, that small because we were doing this so much, this patla sa 5-star bar you've seen, that, and in that, you have to lift the flap, and within that flap they write so tiny. So should there be a font size thing for highlighting if it's like so much high in sugar? All those discussions went behind the back, but at least now we have a draft guideline which you should look up. It essentially talks about these 3 things. One is, like I said, labeling guidelines. One is about banning advertising or restricting it, and marketing role of industry also. So in terms of industry, what it promotes, what it says is not only to reformulate products, but actively promoting moderate portion sizes. As of now, they say that you can eat you open a box of can and it's so happy, so you keep having it. It's like that, that open one Coke bottle and then the whole family should consume it. The portion size, there's no moderation, there's no restriction on that as of now. So we are trying to push that and tell them that it's important to highlight portion sizes. It's important to do things not in aggressive marketing, especially for the HFSS foods. Developing pricing that does not offer minimal marginal cost for more calories, acknowledges reputable science from peer-reviewed journals, not their own industry-funded science all the time, but also a fair, unbiased opinion. I don't know how many of you saw this, but there was a very interesting lawsuit, FSSAI filed against McDonald's here for the Ghiya Tori ad. So there are 2 vegetables, the gourd family, and they said that why do we eat those and why do we care about those when we can have burgers, for example, that was the ad in the papers. So it influences children and the mothers who are pushing every day to eat the green leafy vegetables, and then the children see this ad that there's no point having it and have burgers instead, and it's absolutely the same, it is better and it's this and it's that. So we have slapped them with a suit. So let's see how that, it's not reverted yet, it's still in the court, but that's what happens. Avoiding conflict of interest, that's important, and acting ethically, developing meaningful criteria for self-regulation, and creating a long-term strategy for business and health goals. So now, when I was writing this, when I was doing this, I was thinking that there is so much to learn from the undernutrition space, and we should not miss the bus at the extent to which the infrastructure has been developed, and it's out there, like Usha was explaining, the field, how the frontline workers are collecting data, they are so involved, and I'm not trying to in any way say that increase the burden and ask them to do this side of the story also, but when we've thought out so well how to reach people, when we've invested so much in infrastructure, why are we waiting for the epidemic to get even severe here and then start a parallel, mohim or parallel campaign for overweight and obesity? So the major reason I see that is because there was a major government buy-in right from the start for undernutrition. You see children dying, or you see children's ribs out and really wasted and stunted. It does something to your heart. And it's very it's a sympathetic, like it's more an issue of human rights, and it becomes of life and death. And so perhaps the politicians, the governments buy in this more rapidly, and several national level programs and policies with undernutrition focus exist as of now. ICDS, midday meal, Poshan Abhiyan, Ayushman Bharat, all of them are actually just building on top of each other, which is okay, because we still have a huge burden. The community-based targeting, individual level coverage. But what happens when we talk about take-home rations? What do we talk about? We were talking about midday meal composition. Who will review it with the overweight obesity lens? Why are these figures of 2 billion people across the globe, and at least several million people in India with overweight obesity, not creeping in the discussions of makers? I'll just come to that. 1 minute. The 2015-16 data said, onwards, we've started collecting. The NFHS4 was the first one to collect data on overweight obesity. ICDS CAS, as you know, the computer-aided system is collecting information in real time about tracking each child. So Ministry of Women and Child Development have actually invested in this computer software, or the central system, where each child in each Anganwadi is being real-time tracked. So if on day 1 your weight was so and so, the central server will inform you, this is below 2 standard deviation, go again, this is the follow-up visit, this is how it has to be done. So they are really, that's what they are showcasing. This is what is happening in several of the districts. It's not a complete pan-India movement right now, but it's happening in many states. That's what Sajjan Singh says. So ICDS CAS real-time monitoring is happening. But what happens if they're above 2 or plus minus? It's plus minus 2 standard deviations, right? So what happens if it's plus 2 standard deviations? They have no instructions for that right now, right? So what I'm trying to say here is that right now we have a mechanism. We are trying to track them, give them some instructions. But when will we track this data? This is not in public domain. When will this data come to researchers? When will they tell that this is the burden? And how will we then go back to these kids, for example? And by the time we go back, it will be 5 or 10 years, and they've already translated into becoming adolescents, obese adolescents for that matter, and the risk factors. What then? So my urgency comes from the fact that when we have a system which is being done, why not talk about both of these ends? What about program guidelines? We have all these, like we were saying, SAM, MAM, all these guidelines there. What about overweight, obese guys? Not even one guideline exists on what happens about these children, what happens to the health conditions of these children, complications of these children. They offer, when I went to Niti Aayog last time and we were having a chat with Dr. Vinod Paul, they were saying, Ayushman Bharat is going to take care, we have subsidized costs. But let them become sick and then subsidize cost and then get them treated. We've increased this number of beds, this number of services, this number of good. Very good. But what about the prevention side, which is in our hands, which is in the hands of all of us people? SOPs, MOPs, what are the manual of operations for detection of obese pregnant women, for example? What happens there? The MOUACs, we were using the churis, I don't know, you know about community for finding out, because the tapes were not reliable. There were standard measures, different methods. What happens to that data for detection of overweight, obesity? What about referrals to them? Okay, so you found them. Who treats them then? As of now, we only have NRCs, nutrition rehabilitation centers, to treat undernutrition side of the story. What happens for overweight kids? Is there any counseling? Is there anything which is happening? So therefore, I thought, just to reiterate this nourishing framework, which tells you that the problem should therefore now we start viewing in 3 buckets. The first bucket about food environment, the second bucket about food systems, and the third about behavior change communication. Lindsay Jacks today will talk about food environment and food systems and how these sustainable diets are so important in the context of malnutrition. But what I want you to see here from the overweight obese lens is that policies and all this N to G alphabets are right now very, very scanty, very just like somewhere there, but maybe not there. So we need to collate efforts, or perhaps prepare a consolidated case. Perhaps the onus lies on us right now that we've not made a case strong enough to the policymakers. Or we need to get more voices together, collect more data, and show this. Because overweight, obesity, okay, you can't take a healthy child, and that's sentimental also. You can't call a healthy child a healthy child. Healthy mothers call their children healthy, right? Obese kids are called healthy in our settings. And we, oh, theek hai, acha healthy hai, abhi to healthy hai. Chubby and healthy are these, these are cute words. They're not seen as something which is going to be of problem later on. So most of the mothers don't even know about this. You talk about information for under thing which has been going from years. What about overweight obesity? So in terms of solutions for India, for me, three important things. Life course approach, you've heard this, I know cliched, but it's again very, very important. Intervening in the preconceptional period, again very important, because once you've missed the bus, what's the point then? So this important period is very, somebody was rightly asking about the interventions during that time, trials which are happening. Enough evidence is there, like Musha was saying, we have to grow in the program mode now. Adopting a combination of top-down approaches, whether it's policy initiative, and bottom-up, the Jan Andolan movements, and getting them together is something this is a piece which we wrote. Barry Popkin, I don't know if most of you know him, but he was a person, he's again a very passionate person, writing a lot about LMICs, and he coined the term nutrition transition, and he was trying to show this from a long time, early time, from his work in China and from his work in India, that there are changes which are happening. There are changes which we must start seeing, and overweight obesity was one thing which he was highlighting. And he had convened a conference in Bellagio. So he'd found most LMICs, mentor-mentee. He had invited a pair. So Dr. Reddy and I had gone from India, and we were discussing. We spent a lot of time on overweight obesity interventions there. And this paper came out from there, where in 2013, where we tried to write what are the policy, where are the policy at that point, what policies existed, and how could they integrate overweight obesity at that structure. They have changed, they have taken different names and shapes, but somehow most of them can still be adapted. So that's the India front for me. You had a question, yes, Digvijay.
Probably this question would have been more interesting. So I wanted to know about obesity.
Can you use a mic? Yeah. No, he has one. Because we are recording these sessions, so if you speak on the mic, it will get recorded. Thank you. It's on.
Yeah, so probably this question would have been, more appropriate yesterday. So about obesity, I wanted to know how big is it a problem in non-urban context of our country? So first, I would like to hear about it.
Yes. So we have data coming in now, and I can share papers. It's one or two papers though, but Lancet papers from Soumya Swaminathan and Lalit Dandona's group, our own PHFI and ICMR work together has done tabbing of this urban-rural, male-female from every state in India. So we have the State of India Health Report. I can make that available to you, which shows that it's a myth that it's only in the urban settings. Increasingly higher number of people from the rural communities. It's still not high as our urban, that's right. But the trend is much steeper now in rural areas than in urban alone.
What does NFHS 4 tells?
NFHS 4 also says, I showed you yesterday, that there is a double burden of malnutrition, and most of the urban parts are having that compared to rural less, but none of the rural are not without overweight obesity. So if you want to understand that it's not a problem in rural areas, it's a myth. We have data now to support that. Okay.
Yeah, so the reason I was trying to understand this in context of today's discussion was it's in current scenario to tackle malnutrition undernutrition is itself a very big challenge.
Right.
Government system nowhere is the scenario, today's scenario, it is very difficult, especially the urban undernutrition.
Right.
So when we bring in the discussion of overnutrition, how exactly would that fit in current methodology in government systems to tackle?
It's a big question. I don't think if I had the answer, I would go right there. I'm on many committees, so I should have gone and given that draft plan. But I think what I want to respond to that briefly, and I'll let Usha come in later, is that we have built enough systems and infrastructures over the past several years for underweight, undernutrition side of the story. there are, and we also saw that there's a huge connect in terms of the DOHAD structure, that the genesis of both these problems starts from a poor mother maternal birth outcome, or whether it's her nutrition and other factors determining that, but it starts from that. So there's a lot we can start to lobby about and talk about in terms of a integrated life course approach rather than a feeding to a hungry population approach. So the shift from that just feeding calorie to giving a nutritionally balanced, appropriate nutrition is what my first target would be. And therefore, if you keep repeating the words appropriate nutrition rather than under and over everywhere in most policy meetings or as messengers later on, I think it will start bringing in the conversation. Over the last 5 years, I've seen the change. So this has entered the room at least. So that's a good news. It will not happen overnight, I agree with you, but it will happen faster. It should happen faster than the amount of time we took for undernutrition. That's for sure. 1 minute, I'll let Usha come in.
Yeah, I just wanted to comment. Sometimes maybe using the word perhaps using the language of undernutrition and overnutrition may not help us, because overnutrition kind of, like, there's a lot of the good stuff, right? So that's all what Dr. Menon showed. This is all forms of malnutrition. There's imbalance, either in terms of inadequate calories, too much calories, inadequate micronutrients, because that affects on both spectrums. So that's one thing which the framing that, malnutrition is complex, it has different faces, might help, because then you're not having this tension. We're still dealing with undernutrition. Why are you asking us to talk about overnutrition? Yeah. We're feeding these people. You're telling us you're not taking away food from people. So that's just one comment, and that's how you frame it.
Sure.
I think the second part, and I'd love to hear from you, Shweta. We have no dearth for data in terms of surveys after surveys, which have been analyzed, and fortunately more people are using it for policy. But maybe what's not there is having, like you said, the SOPs or the screening that's happening at the ground level. So if using the pregnancy example as one, you have someone coming in, is weight and height measured for all pregnant women, and you know what their BMI is, and then accordingly they are getting advised. That part, because we've been working on a mode that if I go work in this district in Bihar or in this rural district, everybody's going to be undernourished. That's changed. We're having undernourished women, we're having underweight, overweight, anemic, non-anemic, etc. So I think there's going to be, developed countries have that, but coming in with that screening, and Ari can talk about that.
My question, Shweta, is what is the evidence base that suggests that we know at an efficacy level what works, that we can then ask our implementers to try and develop effective strategies at any level, right? Because without the evidence base, right, the reason we've got so many good policies and strategies around the undernutrition side of malnutrition is that we have good solutions. We have nutrient sensitive solutions, we have nutrition-specific solutions, we have enabling environment solutions,
right,
and they're all efficacy-based. So we can now have Lancet series that suggest that kind of if we get this thing at a policy level, it will work. We don't have that for obesity, right? We have absolutely no evidence, right, that we know what to do. So when we have no evidence that we know what to do, why should we screen an individual person and tell this woman that she is overweight because we don't have anything to offer her?
I think there have been examples now, which we will share from other countries, which have shown to some degree that removing those constraints, whether it's overweight, obesity, or tackling those like taxing, which we will talk about, taxation as one of the financial levers, which helps reduce the consumption of things, which promotes overweight, obesity, which indirectly leads or fuels the NCD burden. So there are, I know wishful thinking, but those are okay. Yeah, please.
I know where Ari is going with this, but I can say in the maternal health sector, I think we know enough not to give more food to women who are overweight during pregnancy. I mean, there's the weight gain recommendations and the things. So as we think about interventions that have been designed primarily with feeding up pregnant women, there I think there is an opportunity that women, as they come in, first getting them in the door is the biggest one in many places, that they are getting tailored thing. And that's kind of where the multiple micronutrient came from, that's something seems to benefit all women irrespective of their BMI. If anything, the ones who are a little heavier benefit more.
No, I also
so those are, I think, so there, I agree. We need to have evidence-based. We can't just do things because we think it's a bad thing.
But I think also, Usha, in addition to maternal childhood, there's also a lot of work from school health, which has shown that if you control overweight, obesity at that point in time, and we know that these people don't translate into overweight, obese adults, and therefore, so early education, for example, school meals, for example, better fruits and vegetables availability and accessibility, these kind of things in wishful thinking, whatever, but there have been instances which have been quoted. So whether it was GNR report or GLOPAN, they all have come out with, when we talk about reducing costs through malnutrition, these have been some successful case stories. So there was a CATCH program, the Child and Adolescent Trial for Cardiovascular Health, which was conducted in 4 states of America, which provided school food service, physical education, classroom curricula, home programs, and improved these qualities in all these parameters, and showed benefit that once if it improves, the childhood obesity, overweight obesity comes down, and the cardiovascular health improves. The Amsterdam also was a recent example. If people saw, it was published in the form of a policy brief as well. They have promoted tap water. They said no fruit juice happening here, and children should sleep more. So, okay. Now, yes, wishful thinking in the sense I can't go to each child's house and tell him to sleep. It's ultimately somewhere a shared responsibility. But coming at the policy level and saying that sleep is important for a child is also very big, progress in that sense. The city is successfully fighting fat by promoting tap water and not taking fruit juices and promoting or encouraging enough sleep. And the CDC, for example, the Center for Disease Control in US, has categorized them at different levels for obesity. This is an example. I'm not saying we have to copy these guidelines and adapt here, but what I'm saying is that these kind of things exist, which can at least inform our next path, next steps. They have a whole bunch of activities and strategies in the nutrition, physical activity, obesity prevention strategies. It's a PDF document, easily downloadable. I've given the link here. Feel free to look at these resources. It puts the emphasis on increasing physical activity, fruits and vegetables, breastfeeding, community level participation. They also have a whole spectrum of strategies, 24 strategies actually, in the early care and education sector, where they say that improving nutrition, infant feeding, physical activity, limiting screen time have been successful in preventing of overweight obesity. There are school health guidelines which are available, again, engaging with students, engaging with caregivers, assisting schools and coordinators to offer this. Community guidelines, clinical guidelines. So, of course, there's a whole prevention bunch, but also our health system should be ready for that extra load of people who are in the already developed risk factors and will be going towards developing diseases. What's happening with screening? What's happening with tertiary care once you diagnostic services, referral services? Do we have enough doctors? Do we have enough capacity to be able to tackle this load? Is also one thing which we've not talked about in overweight obesity so far. Some instances, just like to let you know, in 2013, Tonga had lowered import duties from 20% to 5% for imported fresh, tinned or frozen fish. And in 2016, 15% was implemented on turkey tails, lamb flabs, and the high-fat portions of meat. and they found that these things were able to demonstrate some benefit. It may not be scalable in our countries as of now, because our meat consumption is comparatively lesser than other countries. But like Purnima was saying yesterday, this may change. These are numbers which we so-called believe in terms of India being a vegetarian country. But we saw in her slides yesterday that 50% of the women were not, were not recognizing themselves as vegetarian. They were recognizing themselves or putting themselves in the non-vegetarian category. In Fiji also, something like this, improving fruits and vegetable consumption, removing excise duties, is able to show benefits. Mexico, Dr. Prabhakaran was mentioning this, limits on sugar and fat, whole grain cereals, increasing the tax on sugar-sweetened beverages, along with nutrition education for children and parents, has been found to be successful. In Brazil, which everybody was quoting all the time as a success model example, school feeding was there as a major thrust area. So I wouldn't say that nothing has happened. I would still feel that there have been cases where banning of these countries have done it and have shown less than 30% of them actually started investing in processed foods. Swedish education schools also, they said safe, nutritious, free of charge, and caterers were shown what menus can be used. Some hand-holding was required from the government's end. No sweet drinks. This is something really which can be taken away. The sugar-sweetened beverages, we've seen not even fruit juices which are available. They have 30% sugar. We think take a real juice, no added sugar is written, consume as much as you want. It's just sugar water ultimately, which is happening. So, and it's only concentrate, it's not real fruit, it's made out of concentrates. So I think, just summarizing now, again in terms of overweight, obesity, holistic responses across life course this evidence needs to be started like collating and being there. Improving home environment, not putting the blame on parents alone, but improving in general. School education and monitoring. Surveillance is important. Now, we've not even recorded these values ever. Only from the last 4 years we've started paying attention to this. But a regular investment in surveillance of this is important. From research angles, again, like Usha is saying, collating all these data, putting it out there, increasing awareness, social advocacy, using celebrities. FSSAI was able to do this very nicely. Thoda Kam. I don't know how many of you saw that, but there's an initiative and movement called Thoda Kam. Aaj se Thoda Kam. So that means from today, a little lesser of HFSS, that is high fat sugar, should be reduced. And they brought in a lot of celebrities to endorse this. It was quite popular, at least on this thing. How far it goes in community levels is something which we have to see. Policy measures, taxation, subsidies on healthy foods is also, I'll end with the same slide saying that it's not impossible for us to multitask, but we should develop that second hand out. Right now, we're just focusing with both hands on the undernutrition thing. We may have to develop 2 more from our shoulders and start talking about this together. So thank you. Okay, question, Ishmeet.
Thank you for the talk. I just wanted to ask, you've been a part of several committees and stuff like that with the government and everything, right? So if you look at, again, I'm quoting the CNNS numbers, right? If you look at the numbers for stunting in adolescents, right, where we're coming from, right? So the numbers for stunting are close to 20%, 25%. I'm talking about the age group between 10 and 19, right? But if you look at the number for obesity and overweight, it's very, very low. It's like, as a policy maker, right, it's like close to 5%, 6%, right? So, what is the conversation around it? Because, while talking to policymakers, they tend to think, okay, this seems to be a big problem. Now, it's very, narrow-minded. I understand policymaking in India is narrow-minded, and they don't think a lot about the future and stuff like that. But, how are the conversations, and how can we even, get that thing of overweight and obesity to them and try and make them understand, this might be a bigger problem, right?
So we were just looking at some of the numbers from CNNS. I've got a question for the group here, right? Which is, what is the in a perfectly well-nourished population, what is the expected proportion who are more than 1 standard deviation above the reference level? 1 standard deviation. 2 standard deviations is 2.3. What's 1 standard deviation? What proportion of the population are covered within plus minus 1 standard deviation? 67%, right? Which means that 33% are outside of that, right? So a well-nourished population has 16% who are more than 1 standard deviation too thin, and it has 16% who are more than 1 standard deviation too heavy. The Indian population is currently showing what percentage being too heavy in adolescence?
20.
No. 6%. So you have less than a well-nourished population. You do not have, at this point in time, an overweight epidemic in adolescence. So let's not put the cart before the horse, and right? You need to be thinking about prevention, but you do not, at this point in time, have a overweight public health problem. You have individuals who are overweight, maybe. No, I'm talking adolescents right here, right? But if the argument is, right, that you need to be treating adolescents because they become adults, right, then you need to have a better way of working out who it's going to be, because you don't have an adolescent overweight problem.
I still feel that the children who are now, so this is the data which is the children who are adolescents, but if we focus on the childhood thing, who are on the verge and who will be transforming, I think it's important that we try to focus and use some of our energies into stopping or preventing that transition. The numbers may not be very high, but why do we have to wait for that time for it to become so big that we have to then think?
For something
I know we don't have to put the carrot or the cart and that, but in India, I think it doesn't work like that. We have to start pushing the carrot and the horse behind each other and keep pushing them till the time we get them. Because once the problem is there, what do we do then? Like for us to start negotiating or talking, taking cues from the undernutrition side is important. So while I don't disagree with you completely, but I still feel the need to push this or to keep this in the frame when we talk with policymakers. I would not throw it out just by saying that right now it's not a problem, so let's not focus on it. So I wouldn't agree with that completely.
Because the burden may be higher in urban areas. What the number that we're seeing is maybe an idiot of the overall.
It's not very high.
It's not natural, it's 9%.
It's 9% in urban and it's 4% in rural.
But what we see is in proper urban areas, I mean, it has to be context specific, like as what Shweta is telling, we have to take some things, because most of the upstream things that we're talking about will take some more time to come. So there should be a system or something in place. So as you were mentioning, we see Anganwadi has got a proper ICDS CAS system. And in schools we have school health system and school health record, but mostly it's paper based. If we can think of getting it as an electronic base, then you can automatically have the grading of the children as overnutrition or so, and bring the accountability on the Ministry of Education. Why should always be the health system or someone or the food doing it alone? Why not think of trying something like that? Because just discussing, we go on school camps to private schools and we see when they're obese kids, as a physician, we are duty bound to write something. So we say counseling for diet and thing given. That's all. So where it goes, it just lies in the diary, or maximum a few parents may look at it. But what next? We don't have any probable solutions there. So again, the onus has to be brought on to the maybe the schools, the Ministry of Education, to at least be a monitor there. That's my view. Thank you.
I have a very different question. Since you work a lot with policy in that area, what has been the engagement with textbooks, CBSE, NCERT?
There has been. So we are, so there's a model curriculum which we've developed with the FSSAI on healthy guidelines and on promoting not appropriate nutrition, that like not under and not over, healthy guidelines in for different classes. So from 1 till through class 7 and then from 8 to 12. We have sent the material to HRD for the NCRT books. 1 or 2 model things have been developed. It's called Master Sehat and Mr. Sehat. We've done some modules in schools, which is happening. So these initiatives are happening, Megha. They've not taken the full shape and like pan-India, but yes, they are under consideration. And it's not been a negative response from them. Briefly. I don't want to make one of you hypoglycemic, so, let me know.
So, by the time you just said that this education being developed for school children, but the impact is that the mom of that child is still not aware of what to give. She doesn't know basics in terms of where the protein source is coming from. So, what are we doing as part of empowering these kind of individuals? And I'm talking not only rural, urban, even the
I will tell you,
elite
that's
people.
a school initiative which FSSAI is doing. Again, we've thought of that when we were thinking about a holistic policy. I will not say it's happened in every school, but what we've done is there's a health and wellness coordinator at each school that we've proposed. So usually the guidelines were only if it's less than 10 kilos for 3-year-old babies, find it out and send it out, a note to the parents. But now we've given them charts as per for each of those age groups and said that those regular weighings should also have a message for overweight obesity that your child is. It was not getting a lot of positive feedback from parents' side that the school is like interfering and why is it giving a comment on the report card and things like those. So we had to actually prepare a separate sheet. There's a lot of elements involved there, Rochelle. It's a lot of parents accepting that the child is in that category also to see it as a successful policy. So we are doing it, but at least so the moment we write that the child is underweight, we see next days the juices are coming in, like instead of 2 parathas, 4 are coming in, things like those. They happen, but those have very deep impact from the school. So if we write about overweight obesity, not a similar response was seen. So we are still doing some studies and finalizing that, but we have it in mind, and we have health and wellness coordinators as chalked out as a part of the plan with different schools. 1 minute. For Rishmit's comment, which you said, how do you engage with policymakers? The reason I was telling you is that we've started having these conversations. There are some new IAS officers who are taking joint secretaries and these posts who are recipient to these ideas. They are seeing this happen in real life. Many of the politicians many times rely on personal experiences. So when they are going down in communities and really seeing fat women, that's what is making an impact. Our coming and sitting here as 6%, 9%, 15% was not making an impact. But when you actually drag them down to field visits, and some of them are actually coming down, they see these things happening. Like you said, seeing a phone in the hand of that. When you actually went, you will believe it. When I tell you there are differences. So what we are using is some video recordings, some case taking them on site visits. There are some ways we are trying to engage. We've still not been able to get 100% of their support, but we are trying and pushing. That's all I was saying.
I just wanted to, so people, we don't want the group to get mixed messages. The part is we have to see the data. We can't attribute to something which is not there, and that's the point Arya and I were making, that when you look at the representative data, it's not yet a problem. But that doesn't remove the need. What Shweta is making the course is if you look at the data in adults, and I just pulled up some data in women of reproductive age, we have this what we call bimodal. Half of them are underweight, half of overweight. So you've got to be extremely careful when you're messaging that you don't say adolescents in India are overweight. Yes, they'll always be overweight. But the reason you're targeting, and that's again where I think Ari was questioning, it would be good, and I think there's an opportunity to build the evidence base, that by intervening during the adolescent period, you will stem the subsequent outcomes. And that's where I think preconception is a very nice segue, because there's a lot of strong preconception data to say a woman who is overweight at pregnancy is at equal risk of low birth weight and preterm as an underweight woman. That is not common knowledge right now. And so I think those are so there's the policy argument, but that linking which is going to be important.
I was talking more from the advocacy point of view.
Right, but for the advocacy also, as scientists, as people, we need to use our data carefully. Otherwise, it will bite you back.
Yeah,
Then one more thing which I think hasn't been discussed, but is again maybe more a research question, and we've been talking about it at least in our group, etc. And Dr. Yagnik will be here tomorrow. We know that for Asians, for whatever reason, we have more fat and less muscle at a lower BMI. Right. So I think there's an opportunity, maybe it's only 11% or 8%, but maybe the BMI-Z, we do not have growth charts. We're using international growth charts for doing the BMI-Z of 1. Maybe Indian kids need a different, and until we have the body fat composition or the calibration, we're doing this now in Vietnam, this question's come up, that's another area where we don't really know.
Yeah.
Maybe our kids are fatter, even if they have a lower BMI.
Yeah, and overweight obesity is not the only route to have diabetes. So there are diabetics also, body composition. Yeah. So therefore, yeah.
I want to give you another kind of thought experiment here, okay? We just looked at the data. 25% of women of reproductive age are overweight based on whatever definition was used in CNNS, right? I don't know exactly. NHFS, yeah. Right? So I don't know if that was the 25 threshold or the 23 threshold.
Yeah.
Doesn't matter, right? The number is 25%, okay? We've also shown from the adolescent data that the prevalence of overweight in adolescents, right, is 9%. Now, that means even if every overweight adolescent becomes an overweight woman, and that's not going to happen because, you know, people bounce around, that means that most of the overweight women were not overweight adolescents, right? The math doesn't work out otherwise, right? So the point isn't that you have to focus only on the overweight adolescent. That's the wrong population. Most of those people who are classified as overweight adolescents are not overweight, they're just normal. That's a normal distribution, right? Again, you get into victim blaming if you start focusing on them. What you have is a shift overall that's happening, and you've got what's happening emerging by statistical definitions, a change from a population that has a low prevalence of overweight in adolescents relative to the standard, to a population that has a fairly high prevalence of overweight once the transition to adulthood and presumably 1 or 2 children has happened in the women of reproductive age, right? So we need to be very careful about how we use these statistics and how we message them, right? We know that in populations where there is a lot of overweight, right, like the United States, or I've done some work in South Africa, where, right, that children who are very overweight in childhood, that persists into young adulthood, right? So kids who are very overweight are at risk of staying overweight. But most of the adult overweight, those children were not overweight children. Well, what happens is a very important question. And what happens in women is they have kids, and you get gestational pregnancy weight gain retention. That's a different problem, right? That's not adolescent weight. That's pregnancy weight gain. And that's a whole different ballgame. And what's happening in men is that men just sit around and know what to do, right? So in men, it's physical activity, it's beer, it's kind of the other sorts of things of kind of that happen with kind of men not working in farms anymore. They're working behind desks.